This is LiveWell Talk on New Clinician Spotlight. I'm Dr. Dustin Arnold, Chief Medical Officer at UnityPoint Health, St. Luke's Hospital. Today's episode is another installment in a series on the podcast where we sit down with new clinicians at UnityPoint Health, Cedar Rapids, and get to know them as a clinician and as a person. Our guest today episode is Dr. John Lace, a neuropsychologist with St. Luke's Physical Medicine and Rehabilitation. Dr. John, thank you for coming.
Oh, happy to be here, sir.
Now, you've been here a while, so
Yeah.
getting yourself all established in the community. How do you like the community?
I've loved it so far. Chicago is home, outside Chicago is home, and Cedar Rapids has felt, in many ways, like the westernmost suburb of Chicago.
Okay.
So I fit right in.
Are you one of those Chicago guys that like, oh yeah, I'm from Chicago, and you really live in like DeKalb?
100%.
Okay,
Of course.
all right,
Yeah.
all right, just checking. I went to college with a bunch of those guys.
Did you?
Yeah. You know, it'd be like me saying, oh yeah, I live in Cedar Falls, but I live in Cedar Rapids.
I get you, 100%.
So, what is neuropsychology?
Yeah.
And how would a listener interact with a neuropsychologist?
Great question. And we're often kind of a overlooked field in some
Criminal
ways.
Minds, your favorite TV show?
Why do you say that?
I don't know, because you like psychology. And...
Oh, sure. Less so the forensic, the criminal stuff, but
Okay.
more so figuring out why brains and the mind works the way that it does. So in neuropsychology, we really focus, at least I do, on the assessment of cognitive changes. Usually it's older adults who have memory changes, maybe early stages of Alzheimer's disease, something like that. Family might be noticing, they might be noticing, and we'll kind of figure out what's going on, kind of compare their level of functioning to that of other people their age and their background. So typically, patients will interact with us after a referral from their primary care doctor or a neurologist, sometimes from a physiatrist if they've been on the PM&R floor, and we'll do kind of an outpatient workup to say, how is things going from a brain health perspective? Is there a diagnosis that fits well? Are we concerned about something? And what do we do to keep you at your top?
Before we get into what that entails,
Sure.
Like how often or how accurate, I don't know if I'm kind of being clumsy with this question, but like, is it confirmed that if a patient thinks or family that they might have dementia, that, yeah, that's what it is?
Sure, and that's where we kind of get into the weeds a little bit too.
Okay.
I often think of dementia, the term dementia is kind of the umbrella term, right?
Absolutely.
It's the syndrome that we see in clinic, the level of severity in many ways. Alzheimer's disease or Lewy body disease or Parkinson's disease is the underlying reason for developing the severity of dementia. And so, I don't have a test necessarily in my office to say, oh, it's Alzheimer's disease 100%. But I think what is really cool about our background and training and our specialty in neuropsychology is to put the pieces together, to look at patterns, look at the whole story rather than just, one data point that you might do in a quick outpatient visit with your doctor. We really want to get to know you and help understand what the problems are.
Well, I'll definitely say from my almost 28 years in practice, when your specialty does evaluate a patient, they get it right. I mean, it's really impressive, and I know it's a very intensive interview and brain examination, so to speak. So, kind of take us through what is a session to determine cognitive health and whether or not a disease might be present.
Yeah, you betcha. And that's what I mean. Patients often don't know what they're walking into. So it's good to have this kind of out there. I think of an appointment with me as long. It's longer than a regular doctor's visit for sure. No needles, no x-rays, nothing like that. It's really not invasive by any means. First and foremost, I want to get to know you. And we tend to divide our appointments up into two sessions. First is half hour, truly an interview, not a quiz interview, but more so tell me what's going on. I want to understand, really open-minded, open-ended questions. The second part is kind of what we call our memory testing, basically a test drive for your brain. And that'll be either with me or one of my technicians and kind of put a patient through the paces of, how many words on a list can they remember? How quickly can they do complex procedures? How well can they solve new puzzles and new problems? And again, their performance on those types of tests will tell us what circuitry in the brain is working well or not so well, and how that might fit with the disease process. So all in all, it's a handful of hours in the clinic. Typically, we'll meet again maybe a week or so later to go over those results. I actually find that to be the most fulfilling part, is to kind of explain the what, the how, and the why to patients and their families too, well after the fact. But it's certainly a little different than a quick, hey, how you doing? Quick primary care check.
Yeah, that's Which is great. I mean, that's fantastic. I love reading your guys' reports. But you better set aside about 30 minutes to go through.
I understand
one of those reports. Yeah. When patients are evaluated, and you talked about memory and recall, et cetera. How much of decreased recall is just simply age? I mean, like for me, it's like speed of recall. Like I can't think of something, but then I'm driving home an hour later, and all of a sudden, bam,
pops right into your mind.
You know, it's like my hard drive needs to be cleared,
defragged.
Something like that. So tell us a little bit about that, because I'm sure a lot of people are like, oh my gosh, I have Alzheimer's, can't find my keys, and no, that's not the case.
Right. Great point, because there is, unfortunately, normal aging that gets the best of all of us, and we do forget things. You know, even starting in your 30s and 40s, you will start to lose some of the skills you had even before that. What our process is really, I think, excellent at is understanding the difference between normal aging, as we would call it, versus pathological aging, indications of early Alzheimer's or something like that. So, you know, compared to 100 other 70-year-old women who don't have Alzheimer's disease, if your memory's on par with them, great. Even though that's probably worse than, say, a 40-year-old, you know, something like that, doesn't mean that it's necessarily above and beyond. So, of course, there is normal problems that just come with aging. Losing your keys. What's the word for that thing? Honey, the gizmo that we use for the what-you-call?
Yeah.
Happens a lot, for sure. But I would maybe suggest to patients, if you're worried, of course, talk to your doctor. And frankly, coming to see us is not a bad idea. We can even get a pretty good baseline, you know, just like you would do for a brain scan or a blood test to track levels and stuff over time. We can do the same thing with repeated evaluations over the course of time to really see if there's a problem that emerges.
Yeah, I definitely have had an experience with getting patients into, and just even though it was your team, I mean, you know, even though it was Alzheimer's, it was just relieving the family to know what they're dealing with.
Of course,
you know. It's not, substance abuse. It's not some sort of mental illness. You know, not that that's a bad thing, right? You know, those deserve to be recognized and treated. But just reassuring the family they can make plans. I know that's been a fulfilling or reassuring to the family of what it is.
Couldn't agree more. And sometimes there's something special or unique about taking 50 different problems. I have memory loss. I've lost my keys. I can't remember the word. I'm getting lost while driving. Those are each individual problems. But sometimes giving patients the terminology to say, yes, we call that set of problems dementia or Alzheimer's disease, can take 49 of those problems away and just make it one thing that they can grapple with better.
Let's go back to that, where you talked about the length, your interview and exam. Every clinician knows of the patient that comes to the doctor's office, has this conversation with the check-in person, has this conversation with the nurse. They get weighed, they get their blood pressure. Doctor comes in, hey Gladys, how are you doing? Gladys, I'm fine. How's the medicines? I take her blood pressure, list her heart and lungs, maybe ask about the grandkids, and see Gladys say, well, we'll see you in 6 weeks. She says, thank you. She takes the piece of paper and goes up front and leaves. Gets admitted to the hospital, let's say a couple months later, some other unrelated problem. And you discover that Gladys actually has mild to moderate dementia. It's just when she's kept in her routine at home that you don't notice it. So, you know, when you have a snippet of someone and they're in their routine, you can get fooled really easily. I know I have. And sometimes you run into that with family members. They'll say, the daughter from out of state will call and talk to grandma like every day, but it's the same conversation they've had for 20 years. You know, and they have that you see that ingratiating. They don't know what they had for breakfast. You ask them, the usual. It was good too. I really enjoyed it.
Oh, don't worry about it, honey. It's great to chat with you.
Yeah. But then the daughter lives in town's like, no, mom's been losing it for a long time. I see her every day and I spent time with her. And that's always, it's humbling when you miss that, you know, as a clinician. But I think that support or allows people to understand why your interviews are so in-depth and two-part, and that recurrence of seeing someone.
I agree with you 100%. I joke, and I've had that experience a handful of times even this week of, you know, if you just met the patient on the street, you'd be like, oh, totally fine. But then when you really put the screws to them and really do some evaluating, it starts to become more evident that there's a real problem.
Yeah.
And so, I like your point that overlearned, hyper-familiar environment can be a really safe one, and patients can succeed in that environment. But then there's such a risk for one thing going wrong, or having to fix a light bulb, or oops, the stove is off, and I don't have the problem-solving capacities like I once did to kind of make those adaptive next steps.
I remember once there was a news story of this. They were elderly couple driving in their car on Main Street, like 100 miles from they lived, but they lived on Main Street in the other town.
Oh,
and they were going up and down this street, and the police are like, "Hey, wait!" And they're like, "Well, we can't find our house. We live here on Main Street, but we can't find our house." And just getting out of that routine, it really can show up, and it can. I don't know about your experience, but sometimes when patients get admitted to the hospital, I have that conversation with the family. Say, I suspect there's a little mild cognitive impairment, and grandma may get really confused getting out of a routine. And it's so much more reassuring to the family. They walk in day 3, they're really confused, right? And then they're either like, "Oh, you said this was going to happen," as opposed to not having that conversation. Grandma gets really confused and it's scary.
It can absolutely be disarming and alarming, I suppose, to families. I think that's what I really value. We call it psychoeducation, meaning teaching and explaining things in as common of language as we possibly can to make things more accessible, and say, mom might have these problems now, and if you're noticing that, again, it all fits within what we're thinking this could be. Or I wonder if these problems have been going on longer than just in the hospital, and usually somebody will say, we have been noticing. Perfect, because now we know what to do about it.
Right.
Because if it's just this amorphous blob of problems, it can be really, really scary.
And it can be very, as you know, and as listeners will know, it can be really stressful on the family when someone starts to have dementia, particularly if they're agitated or, mean, which can happen.
Yeah.
And I know. Now, have you seen as far as therapies for Alzheimer's improve in your career to the point where you're starting to see some treatment that's you're optimistic about? I know we had that. I can't remember what's the one drug that came out.
Lecanemab.
It was like $2 billion a dose, and everybody's like, "Yeah, great. I'm unless I'm a country and print my own money, I'm not going to go buy it."
That would be nice, wouldn't it? Right. Yes, I've seen things advance, and I think the treatment is much more multidisciplinary and comprehensive these days, and I think that's a big benefit. So certainly there are some benefits of things like lecanemab, anti-amyloid therapies. They're getting a lot of attention, and some of them seem to work. Are they perfect, and do they cure it? No, of course not. But we always say that they might be able to help slow things down. But again, there's many other behavioral things that can be done to also slow it down. We forget about basic exercise and good nutrition and sleeping well and staying cognitively active and stuff. I think we forget that the brain is an organ of the body too, and it needs good blood flow, good oxygen, good nutrients, and the science is pretty firm that being as healthy as you can be preemptively, but also even to the mild stages of it, can help slow down progression over time. So yes, I think the treatments are really cool, and I'm all for people being educated about things like lecanemab, and the like. But also there's a heck of a lot of behavioral things that can be done to help slow the process too.
And I wouldn't want to overlook an opportunity to mention this, but cigarette smoking it not only can cause associated with Alzheimer's, but also small strokes that can cause vascular impairment.
Certainly, yeah. I mean, it's best not to smoke.
Yes,
right?
No, I mean that's.
How many times do we tell patients that? But it's certainly a risk factor for many, many things.
The old joke, the patient says that should I stop smoking or just cut down? And well, if I was punching you in the head, would you want me to stop punching you in the head or just cut down on the number of times?
Of course.
So what got you interested in this?
Yeah, well, we're a healthcare family through and through. It's kind of my upbringing. My dad's a physician, a surgeon by training. Didn't really practice. He's done a lot more consulting, kind of the R&D side. My mom's a geriatric OT. My sister's a nurse. And so healthcare was built into us from the get-go. And finding the intersection of human behavior, neurology and neuropathology and functioning in real-world settings was kind of the perfect merge for me. Realizing that psychology, I'm a clinical psychologist by training, but I don't sit and do psychotherapy and talk about your mother laying on the couch type of thing. There's certainly a place for things like that, but that's not me. But understanding the role that being a psychologist can still have in the patients' lives that I care quite a bit about, it's really, really rewarding. I always say, patients are people, and people can be puzzles, for better or for worse. And I think that having the opportunity to help people figure out some of what makes them tick and what might be going wrong is really, really rewarding.
I definitely found in my own practice, my own career, that the longer I've been in practice, the more interesting the psychology and psychiatry of healthcare is. Just it's such, particularly mental health, is such an influence on your overall health that it's just it's amazing. It really is, and it's intriguing.
Couldn't agree more.
What do you do for fun?
Well, since being here, I've been outside a lot, and especially with it warming up. It's early June right now. Been out to Mount Trashmore a handful of times, getting my steps in. Been out to Palisades, Kepler a handful of times. I'm sure folks have seen me out there hiking. Trying to stay active myself. I figure if I don't practice what I preach, then it might be
that's very true.
It might be not worth preaching at all. But trying to keep good and active with being outside as much as I can. Been getting a little bit more into home brewing these days. It's kind of fun to have a little science meets art meets something you can drink at the end of the day too. So trying to keep good hobbies.
How'd you get interested in that?
My dad and I, on a whim, a few years ago now, my folks really didn't drink when I was growing up for whatever reason, and I bought them a bottle of wine for their anniversary just as kind of a tongue-in-cheek joke, like, haha, here, enjoy this. And my dad was like, that's pretty cool. Why don't we get into this more? And so we just started researching and looking, and sure enough, we got the buckets and the equipment. And if you can follow a recipe, you could probably do it. And it's pretty fun.
Beers or wine?
Yeah, beers is my specialty. As a white guy from the Midwest, I'm contractually obligated to like craft beer, right?
Like
IPAs and all that stuff. Yeah, but no, I do like beer quite a bit for home brewing. Yeah.
Interesting.
It's a lot of fun.
Yeah, that sounds.
I'll bring one into the studio.
Yeah,
next
you'll
time.
have to. Well, Dr. Lace, thank you again for joining me. It was fun to get to know you, and a subject I find very interesting. It's always good to talk about neuropsychology as well as psychiatry. And we're glad you're here with us today, and glad that you're enjoying yourself here at UnityPoint Health, Cedar Rapids. Once again, this is Dr. John Lace, a neuropsychologist with St. Luke's Physical Medicine and Rehabilitation. If you'd like to schedule an appointment with Dr. Lace, call St. Luke's Physical Medicine and Rehabilitation at 319-369-7331. Thank you for listening to LiveWell Talk On. If you enjoyed this episode, don't forget to subscribe, and if you want to spread the word, please give us a 5-star review and tell your family, friends, neighbors, strangers about our podcast. We're available on Apple Podcasts, Spotify, Pandora, or wherever you get your podcast. Until next time, be well.